My name is Amina, and today I'll be talking about applications. I actually updated this, but I think you're using like a yesterday's version. I updated the slides this morning.
Would it be okay just to use these or?
So I'll be talking about applications of large language models in healthcare. But I will start by just going straight to the point. I don't want to bore you about like how LLMs were made and all that. So I'll just talk about the challenges in clinical care first. And then from there, we'll talk about like how AI can help and their limitations too. So the first problem I'd like to talk about is physician burnout. I'm not sure if most of you here understand that in clinical care, a physician has to like attend to several patients, and sometimes, or in fact, most times, you have to like document your encounters with a patient. In fact, a study from Medscape reported that 42% of US physicians experience burnout. And one of the most popular causes of burnout is the time the doctors spend in documenting patient encounters. So is it possible for us to automate this EHR entry? And if this is possible, will it help reduce physician burnout? So that's just a question, and I'll answer this question later. Another example of a clinical care challenge is that emergency medicine physicians have the highest burnout rates. I can say this because imagine a patient is sick in the middle of the night. The first place the person is going to go to is the emergency department. Imagine if you have so many people coming to the emergency department, all with like a weapon or something. Physician department, the ED becomes very busy, and then the physician becomes like really stressed out. So this also can add to the physician burnout. And when a physician is stressed, it can increase the patient's risk of medical errors. So we feel like better triaging can actually help, because if we have better triaging systems, we can divert low acuity cases to like other, maybe primary care and so on, and this might help. So failure to address like issues like physician burnout and maybe proper triaging in the ED department can lead to like diagnostic errors. So this image here is just trying to give us a summary of what diagnostic errors are. So diagnostic errors are, in summary, a leading cause of death. And this figure shows that over 18 million diagnostic errors are made each year. And out of these 18 million diagnostic errors, 74,000 of them can lead to death. But the good news is that diagnostic accuracy can be improved if we consult multiple physicians. Like, so if, for instance, I'm a patient and multiple physicians are looking after me, but it's expensive. And think about like low middle income countries. They don't have the luxury of many physicians. But we can supplement the physician's workflow by using automated diagnostic tools. So how can AI help? First, I'll just give a brief summary of what AI is. In fact, I asked an AI system this question. So AI, in summary, is a simulation of human intelligence in machines, enabling them to learn, reason, and make decisions. But AI is a lot. We have so many branches of AI, and today I'm interested in large language models. So a large language model is a subset of AI that's trained on massive data sets to enable this machine understand, process, and generate human language. So this has been trained using deep learning. And large language models can generate text. So the input of a large language model is language, and then the output is language too. It's interesting because it looks like it's understanding you. So an example, like these are examples of large language models, Google Bard and OpenAI's ChatGPT. So, but this is just a definition of AI in general. But what about AI with respect to healthcare? Several studies came out after ChatGPT to tell us and show us that large language models like ChatGPT encode clinical knowledge. A study from Google. Another study also came out from Stanford trying to tell us that large language models are few short clinical information extractors. So what it means is that these large language models can extract clinical information from text. So in essence, they're just trying to tell us that these models understand clinical language. Then this popular study also came out where ChatGPT was compared to like some physicians or medical students. They compared them in the United States medical licensing exams, and they showed that the ChatGPT models outperform most medical students. And this blew up the whole large language models in the medical care, and everyone started thinking about like, how can we actually use these AI tools to improve the clinician workflow? So now I'm going to talk about some of these applications that have come out post ChatGPT to help improve the clinician's workflow. So I'll start by talking about each of those problems I brought earlier and how AI is trying to help solve them. So let's talk about the physician burnout problem in terms of the documentation. So this image here is a AI-powered medical voice dictation and scribe system developed by Intron Health. This is actually used in low middle income countries. You can see there's a voice panel. So imagine when a physician comes into, when a patient comes to see a physician, the physician has to just turn on the system, and then this system starts like documenting the encounter between this patient and the doctor, and it starts to populate each section the doctor is talking about or the physician is talking about. So for instance, here is the doctor is interested in the presenting complaint, and this system is recording it and automatically populating it. So tools like this can help alleviate documentation burdens and improve clinicians' workflow. But it comes with problems. So this here is a snippet from Dr. Gordon Sheet from Harvard, the DEX 2024. So in summary, what he was trying to say here is that this voice assistant are not perfect. In fact, he tested a tool. It missed key information about like social data relevant to the patient's health, and it also made errors in drug effect. And this is also worrisome because sometimes we can think about like over-reliance in the doctor. So some doctors can become very reliant on the AI tool and becomes like he can lose confidence in his or herself. So other problems are like security problems, because imagine this tool is taking the voice. What is it going to do with this encounter? Is it going to be used to train another AI system? So those are like some of the questions we need to ask ourselves. Another problem with these tools is that it leads to biases. So because these models are trained most times with like Western data, when they take them to maybe a low middle income country, it doesn't work effectively. So there's a lot of testing that needs to be done to actually make sure that if this tool is built with the data from the United States, it can actually work in maybe Indonesia and so on. So now we move to another problem, the emergency department problem. So here I'm interested in like triaging, because one of the biggest problems with the emergency department is having many patients that needs emergency care. So is it possible for us to use AI system to improve like self-triaging? So we have several technologies that try to improve stroke recognition, but there are very few that help patients to self-recognize if they have like a symptoms of stroke. And if they recognize they have a symptom of stroke early, if they go to the emergency department earlier, it might help save their lives. So this study here was conducted using patient's information from Rhode Island Hospital. And this study involved patient history and physical exams. And then the ground truth was actually gotten from a neurologist. So we just took a random subset of 500 records and we fed it into ChatGPT. So there are different types of ChatGPT system. So the one we all use on our phones is the chat interface. And then there's a different version where if you want to like send multiple requests, it's called the API version. So we wanted to see if the version on the phone will behave similarly with the API version. So that's why we had to use two different versions to see if we ask these two different versions a question about a patient's health condition, if we get similar responses or similar behaviors. So the prompt just requests 5 most likely diagnoses and what level of care should the patient seek. Should the patient stay at home? Should the patient seek routine care, or should the patient seek emergency care? So this figure here, this table here is just a summary of the results here. So the ChatGPT 4.0 is the chat interface one, and then the 4.0 is the one that you have to send through the API. So if you look at this, the sensitivity here is the chat version has higher sensitivity compared to the API version. But if you look at the PPV rate, it has a lower PPV rate. So in summary here is that these language models have the potential to help, but there's a lot of variation in their behavior. So how am I sure I'm gonna get 100% from this version? So it's worrisome, and we need to actually like do some kind of clinical trials or like randomized control clinical trials before we allow patients to actually start using these systems. So, and then the last problem I'm going to talk about is the diagnostic error problem. So here we try to see if these large language models can actually, we've tested them for like triaging, we've tested them for like documentation. Can they actually perform complex diagnostics? Because the study compared them to like medical students and showed that it passed the United States licensing exams. So what will these systems do if they are faced with actual complex diagnostics? So in this study, we designed different prompt strategies because like Dr. Fraser said earlier, these systems are sensitive to prompts. So a prompt just means how we ask this model questions. So we tried out 3 different prompts. That's what we have: approach 1, 2, and 3. And we wanted to see how consistent these models will be depending on the different prompts. So this figure is just trying to show us feeding these different prompts to the language model and getting their different responses and just seeing if they are consistent. So we tried different models here, the Google model, different versions of ChatGPT, and the medical language model. And then we also compared them to the human consensus. So this case is, I'm sure you're part of the New England Journal case challenges. So we took some of these cases, and some of these cases are already answered by some physicians online. So we just collected the results. The dotted line, the black dotted line just shows the average human consensus. And the biggest takeaway here is that these language models have the potential to, in fact, outperform the human average consensus, but it all depends on the prompt. If you look at approach 1, their performance was really bad. But the problem is, how can I know which prompt to give these models beforehand? How am I sure if approach 1 is the best prompt, or approach 2, or approach 3? We still don't know. So we need to like do a lot of studies with these models before we just deploy them and say, oh, they are perfect or they are ready to be used. So the biggest takeaways from here is just to say that these AI tools have the potentials to improve diagnostic accuracy and care, and in fact, improve the clinician's workflow. But they face challenges in terms of prompt sensitivity, the privacy risk, because if I put in my data into this AI, where is it going to go to? And then they have like biases, and then they're just inconsistent across platforms. So to ensure effective safety and use of these tools, we need to do more tests. We need to conduct more evaluation. And I'm a computer science student, and I tell some of my colleagues that when we want to build these tools, we need to work with the stakeholders, that's the doctors, but we need to come together and work together to improve these tools for our improved workflow and to improve patient health care. So yeah, thank you. Oh, sorry, I have one more slide. If you're interested in like getting started with like some AI tools, the library at Brown have like some nice websites to tell you about AI. And then there's the Advanced AI Center also like have like consultation times and so on. So you can just take a picture of this, and you can also contact me if you have. Thank you.
Thank you. Question for Amina. Yes, yeah.
So it's great work. So I think you touched upon about the different ethnic background when you were doing this data analysis and machine learning. So the models you are developing here, so are you testing that in like a global south or other ethnic group places or low middle income countries to see the accuracy? That
Well, yes, it's a really big question. So the only project I'm currently working with Joe Hogan, where we're actually developing models to predict missed patient visits ratio in patients in AMPATH in Kenya. And so there we're looking at a whole group of patients and very diverse community there, a lot of different health facilities across a large geographic area. So we are finding some of those questions even in that community. But I think your point is absolutely critical that we don't even have very good consistency in Rhode Island with these models at the moment. So clearly, there's going to be some problems when you try to use systems in different places. And I think so Ada did a study, this company did a study in Tanzania where they actually modified their system and added 148 new diagnoses that were common, more tropical diseases that were more common there. And got some reasonable results by sort of really carefully tailoring it to that particular population. With large language models, we're going to do some experiments, but it's really important we actually measure how well they behave. And as you see, the triage thing is interesting. I don't think many people reported this, but we saw it from that very first study. We're seeing it very frequently with the stroke data that Amina talked about, and also other data sets as well. So it's an ongoing problem that the system is actually coming up with a probability of a certain diagnosis, and then coming up with a probability of a certain triage, but possibly the twain shall not meet. They're different parts in this really complicated network, and so that's kind of worrying. I think, because we want things to be consistent with the same problem in the same situation.
Yeah, and to add to his comment, so one of the other problems with testing these tools in low middle income countries is that these tools are tested via text. And the problem in low middle income countries is documentation. Most of these hospitals have not documented patient care or anything. So if we don't have the document to test this patient, we can actually test these tools. So some of the studies we are working on now is actually work with doctors in low middle income countries, collect like past exams, talk about like possible questions that are focused in like maybe in the African setting, and we try to test these models to see if it will actually answer the question. And it's for sometimes it does work, but in general, there's still a lot of work that's needed to be done.
Hey, so it would be interesting topic. I'm using AI to like clean up documentation, to take patient notes and things like that, and to, compare like really well written statements and things like that. Seems really attractive. But the problem is that what about responsibility with the data? How do we know whether we can use it? Is it permissible? Like, for instance, if you're on a study section and you want to use it to summarize your notes for study section, that's not allowed. Age. So in the clinic, are they facing similar kind of things?
So, I mean, I think there's been, some contracts and, some discussion about how to handle this, but it's still a work in progress, and there are concerns. So, Ross Hilliard used to work, Brown and actually now in the main medical center, was describing how they were looking to do a contract like a year or so ago with a company to do this ambient recording. So you have the microphone in the room that picks up both the physician and the nurse and the patient as well. And then it processes it through voice recognition, which is kind of relatively deterministic and produces a transcript. And then the transcript is then fed to the large language model like ChatGPT to actually generate a summary. So the different stages are quite important. And Ross said that initially the company said they were not going to give them the transcript. The company was going to keep the transcript for their own use. And so they would then end up with a summary generated by the large language model, but not know what the real data was that was collected, which I was like, no way. It's like a disaster, right? Because you don't know if you've got something wrong, you can't cross-check your stuff, and they have the data to cross-check you. So it just, there's some real concerns there. And I think
all of that information is now being recorded, and anything you say to your doctor is now part of that transcript.
It's a huge problem, yes. And we're seeing that, that information is then being sent to like Nuance as a big data center in Massachusetts, one of the leading companies, presumably hanging on to this data. And there's questions about how to do that. So regulation is very important.
Another question. Any questions online?
Yeah.
All right, well, thank you both.